Yes, there's no disclosure. Yeah, DORV is a type of ventricular arterial connection in which both greater artery rest entirely or predominantly from right ventricle. The incidence rate is about 3 to 9 per 100,000 living births, account for 1 to 7% of CHD. DORV can be associated with other cardiac anomalies, such as coarctation, IA, and AVSD. DORV is a countertrocal defect, anatomically lying between VSD with aortic override and TGA with VSD. It's classified into 4 types based on VSD location related to greater arteries. Although usually large, 10% of the VSDs are restrictive. Rarely, they may be small or multiples or absence. In 2000, Waters established a functional disclassification for DORV to address its anatomical variability and guide intervention, which was adopted by STS and EACTS. The relationship of the VSD with the greater vessels and the presence of a pulmonary outflow obstruction are the key features in this classification. Biventricular repair is generally preferred as it provides more physiological circulation compared to fountain circulation. The main surgical techniques are summarized below. And with optimal bacterial environment is a vital component for post-operative care. This requires not only necessary motor equipment, but also a comprehensive systematic motility. Together, these elements form the foundation of the effective patient supervision. DORV patients are typically young, critically ill, and may have multiple anomalies. They have a low cardiac reserve, relying on high heart rate for cardiac output. Immature lung predisposed to atelectasis. Insufficient renal function leads to fluid overload. They also face high risk of malnutrition and neurological injury. In major Chinese heart centers, the in-hospital mortality of DORV has fallen below 3%. Now, post-operative care strategies focus primarily on the management of early life-threatening complications. First, low cardiac output syndrome is a well-recognized complications following pediatric cardiac surgery, characterized by an acute reduction in cardiac output. It's typically reported in 25% of children within 6 to 18 hours after surgery. It's associated with longer mechanical ventilation, longer ICU stays, and increased mortality. LCOS results from left and right ventricular dysfunction caused by ischemia, myocardial apostosis, altered load condition, and decreased contractility. The key to medication the LCOS in the post-operative period is early recognition and timely intervention. It's important to assess cardiac function, cardiac output, and tissue oxygenation, along with hemodynamic parameters such as CVP, heart rate, and blood pressure. Therefore, if any 2 or more of the following 8 clinical criteria are observed, LCOS should be considered. The optimal timing for therapeutic interventions for the LCOS is period to the onset of the end organ ischemia injury and subsequent failure. A comprehensive strategies for LCOS including optimizing of preload, manipulation of afterload, vasoactive medications, mechanical ventilation, and mechanical circulation support. Assessing the heart's position on the pressure volume curve is key to determine the optimal preload. A positive response to fluid, such as decreased heart rate or improved blood pressure or venous saturation. It includes the preload reserve. No response suggests the cardiac reserve exhaustion and the need for inotropics. Further fluid only raise filling pressures, increase oxygen demand, and pulmonary edema. Once adequate preload has been established, inotropic support is indicated. Catecholamines such as dopamine and epinephrine are first-line inotropics, but can increase the heart rate, myocardial oxygen demand, and arrhythmia risk. Maynardo reduces both pulmonary and systemic vascular resistance. RCT research showed it can lower the risk of LCOS by 64% relative risk in the first within 36 hours after surgery. Although not typically inotrope, calcium is essential for myocardial contraction and vascular tone, especially in neonatals. Faster pressing reduces the fluid and catecholamic needs, but may lower cardiac output by increasing systemic vascular resistance, especially in patients with systolic dysfunction. Positive pressure ventilation lowers afterload by raising intrathoracic pressure, benefiting those with pulmonary edema. If about therapies failed, ECMO should be considered. It's the leading cause of post-operative ECMO deployments with a survival rate around 50%. The timing of ECMO initiation is a key determinant of outcome. Enlargement of VSD carries a high risk of conduction system. The incidence rate of AVB is between 4 to 18%. Epicardial pacing wires were usually placed during surgery. However, a small group needed the pacemaker implantation. The management of the GAT includes sedation, reduced inotrope use, maintaining electrolyte balance, cooling, and using anemidomin to combat the sinus aneurysm. Sometimes ECMO is needed. It's important to know that GAT should not be cardioverted. Pulmonary hypertension crisis is the main cause of the early deaths. The clinical manifestations include a decrease in blood pressure and arterial oxygen saturation, and an increase in CVP, followed by hyperkalemia, acidosis, and kinetosis. Comprehensive monitoring should include vital signs, hemodynamic parameters, echocardiography, X-ray, and cardiac arterial catheter. Treatment strategy involves deepening sedation and management complications such as pneumothorax or pleural infusion. Inhaled nitric oxide or iloprost can be used to reduce pulmonary vascular resistance. Inotropic or vasoactive agents ensure the hemodynamic balance, maintain mild hyperventricular to reduce pulmonary vascular resistance, so it may reduce the cardiac output. If ineffective, ECMO should be considered. Pulmonary infection. Pulmonary infection is associated with high mortality, increased duration of mechanical ventilation, prolonged ICU stay, and elevated hospitalization costs. Risk factors for pulmonary infection include preoperative mechanical ventilation, malnutrition, low weight, and long CPB time. Common pathogens include gram-positive and negative bacteria, virus, fungi. The treatment of the pulmonary infection involves the structured antibody regimen, initiated with broad-spectrum coverage, and later tolerated according to control results. Antifungals are added if necessary. Lung-protective ventilation with a low tidal volume and optimal PEEP is implemented. Bronchoscopy is used to obtain samples, clean secretions, and deliver medications. Early internal nutrition and maintaining a negative fluid balance are also essential to reduce edema and support recovery. The next is AKI. It's diagnosed using the AKI network carrier. The incidence ranges from 30 to 60% within 48 hours. Risk factors include younger age, prolonged CPB time, and DHCA. The pathophysiology involves ischemia, reperfusion injury, systematic inflammatory response, oxidative stress, overactivity of the RAS, and fluid overload. AKI is also associated with advanced outcome, such as prolonged mechanical ventilation, extended ICU and hospital stays, and increased mortality. Fluid management often involves restricting total fluid intake to 2/3 of the maintenance volume to prevent fluid overload. Although diuretics are commonly used, they are frequently ineffective and may be associated with higher mortality. In contrast, Renal vasodilators and inotropics can improve the glomerular perfusion by enhancing cardiac output, thereby mitigating the AKI. PD remains the preferred renal replacement therapy, as it avoids bone injury and hemodynamic instability. Difficult feeding, absorption disorders, and increased energy consumption lead to a high prevalence of malnutrition and growth delay. This condition is associated with the prolonged ventilation, increased infection risk, extending ICU and hospital stays, and higher mortality. For most infants, post-operative nutrition support should be initiated within 24 hours, achieved more than 50% of the goal intake by 48 hours, and targeting an intake exceeded 1.3 times the IEE to ultimately to catch up growth. The experts' consensus on nutritional support for CHD, chaired by Dr. Xumi Mo, provide a comprehensive protocol on nutritional support method, timing, route, and formula. It also includes the details for special conditions such as chylothorax, NEC, and Fontaine circulation. For sake of time, I will skip the details. The last one is the brain injury. It occurs in 10 to 35% of the patients preoperatively, and 33 to 75% post-operatively. Many types of brain injury include white matter injury, stroke, and intraocular hemorrhage. Clinically, cases are often asymptomatic. When present, symptoms may include seizures, abnormal muscle tone, altered consciousness, and difficulty feeding, and increased risk of the long-term neurodevelopment impairment, include motor dysfunction, cognitive impairment, language and learning disabilities, behavior and physiology problems. Monitoring techniques such as NIRS, EEG, cranial ultrasound, and MRI are used. In addition, detailed clinical neurological assessment should be conducted and documented every 4 to 8 hours. Acute supportive care aims to achieve the systemic stability and secure the cerebral oxygen and energy development by optimizing perfusion, ventilation, and metabolic homeostasis. Key strategies involve maintaining cerebral perfusion using fluid and active agents, avoid abnormal oxygenation and carbon dioxide life, correcting metabolic disturbance, and using neuroprotective medications. It's worth noting that long-term rehabilitations and neurodevelopment interventions are crucial for improved quality of life. A successful outcome relies on several key principles. Early recognition and continuous monitoring are paramount. Aggressive management of primary hypertension and systemic inflammation is crucial to reduce mortality. Strict fluid management prevents secondary injury to brain, kidney, and lung. Early initiation of internal nutrition could improve clinical outcomes. Thanks for your attention.